We're going to talk probably for about 15 minutes or so about trauma-informed pain care. You'll meet Dr. Jeremy Fletcher in a moment, who is a specialist in trauma-informed pain care. He works for an organization called Veterans Recovery Resources, which is a non-for-profit organization that provides mental as well as physical health services to veterans. And he's, of course, leading the trauma-informed pain care course, which is about to start in just a day or so. So without further ado, we're going to have some slides for you. We'll share the screen and then we'll have some Q&A at the end. Okay, so I'm going to make Jeremy the host and then we'll get started.
So thank you again for your patience and grace this morning. I am very excited to be bringing you this course in trauma-informed pain care. And I think I need to start first by saying that I've had my own traumatic experiences. And so I didn't just outreach and say, man, I really want to learn a lot about trauma. I think trauma tried to learn a lot about me. And in the process, I really began to understand the influence of trauma, both on my physical body, but also in my emotional and spiritual body as well. And so that's what I hope to share more with you today, and then be able to address any questions that you have about the course. So we'll start first with a brief definition of trauma. It's basically an event, a series of events or circumstance that is experienced by an individual as physically or emotionally harmful or threatening and has lasting adverse effects on the individual's functioning and physical, social, emotional, and spiritual well-being. There are three things that we want to describe as 3 E's. So there's an event that has been experienced, and that experience has created a lasting impact in someone's life. And so as we, as physical therapists and other clinicians who are treating persistent pain conditions, what we really are talking about most of the time when we're thinking of trauma and its influence on the body's ability to perceive pain and generate a pain experience, we're really describing a threat response. And as you may know, our threat response is heavily influenced by portions of the brain that control that threat response. And this is amazing work. I think that Hannibal has sort of led the effort on describing what's considered, from my perspective, the integration of the psychological aspects of the pain experience, as well as the stressor as it's perceived. And I think it's important to recognize that the threat response is really what is continuing to drive most of the persistent pain conditions that we all see in clinical practice. So as you might be able to see on this slide here, what this schematic explains is how this stressor or the fear-based threat. And in trauma, there is an event that is experienced that does have a lasting impact. And so a lot of our reactions as well as responses to traumatic experiences are heavily regulated by the amygdala and its connections to the vagus nerve, as it influences our the physiology that we, that drives a lot of the endocrine responses that persist in pain and inflammation and depression. So what you really begin to see is the influence of how our body reacts to stressful situations. So as we kind of work our way a little bit through this schematic, we have this fear-based threat or this response. And then we have a physiological stress response, which is regulated through epinephrine and norepinephrine and our cortisol levels in our body, right? And then based on generally previous experiences, namely adverse childhood experiences and how those influence how our body really reacts and has been trained to react over time, and our nervous system has developed as a result of the environment that we've been in, we adopt or really have these adaptive or maladaptive responses. So just to give you some context on this particular story that I'm hopefully painting for you at this point, is my own pathway that I had as a child who was, I grew up in a home where I had a mother who was abused. She also was someone who, she was an addict. She was addicted to drugs and alcohol. And as, growing up in that environment, it really had an influence on my nervous system and how it's developed. And there's many benefits to that. There's also many risks. And so some of those risks include how my body just generally reacts to trauma. And so having a war experience as a veteran who's been in a combat zone in Afghanistan and experienced both small arm fire, as well as someone who has, experience where you're constantly under threat, my body knows how to react to those things. And so I had my own catastrophizing, rumination, and feelings of helplessness and symptom magnification that led to a prolonged or excessive activation of my hypopituitary adrenaline system, which really led to me, led to adrenal fatigue. And so that resulted in systemic inflammation, ongoing pain, and subsequently a diagnosis of PTSD, anxiety, and depression. So I became essentially my own patient, which was a very interesting experience. And fortunately, through counseling, through the use of medication, through exercise, all sorts of pathways, I've been able to recover from that experience. And now I'm able to take that experience and help others, particularly as veterans, as part of a nonprofit organization in South Alabama in the United States called Veterans Recovery Resources. So, for me, I feel like trauma is a privilege, and it's something that has led to growth for me personally. And so as I've began to study those concepts and constructs, and now help lead an organization whose primary mission is to address trauma and pain, those things heavily influence everything that I'm doing at this point, and why I'm so passionate about bringing this particular topic to you through the Integrative Pain Science Institute. So we have the trauma and persistent pain image here, and so what I would like to also consider as you're thinking about this, and as I would, as I think about this quite often, is how are people currently coping and adapting to our current environment. And so as we think about the current environment we're all in, I know that all of us are affected by a COVID environment. All of us have this potential situation that we're in where this experience that we're all in is leading to some sort of effect. And there's many studies out there about how people are coping and adapting. And what's interesting to me is some people are adapting well, and some people are not adapting so well. And that's whenever they hopefully will seek care, and they will find you, and you will have the ability to walk them through these things. So on this slide, you see that as the definition of trauma describes, there's lasting adverse effects on the individual's ability to function in both physical, social, emotional, and spiritual aspects. And what's interesting about trauma and concepts like post-traumatic growth is that there is a need to integrate the person's spirituality into the recovery process. And so as we can see from a 2017 study from the American Psychological Association, this is how people tend to cope and adapt. They find ways to regulate their nervous system through listening to music, exercising and walking, prayer, or meditation and yoga. So there's implications for the spiritual, as well as our need to socially connect through these challenging times. So I definitely did want to highlight that as well. Another thing I wanted to point out today is the different adverse childhood experiences. Some of you, that may be a new term, it may not be a new term for you, but there are different experiences that we have that in our childhood that influences how our nervous system develops. And when we really get to look into the data around this, we are learning more and more about the negative effects of adverse childhood experiences on prolonged health outcomes. And I'll show you a slide in just a moment that helps to better illustrate that. But at this point, you might be asking, as I did, what are these adverse childhood experiences? And essentially, they're broken down into 3 categories, and that is that of abuse, household dysfunction, and neglect. So as you look at these can be broken down into sexual, verbal, or physical abuse. Household dysfunction could be people that have grown up in an environment where alcoholism or addiction is prevalent. Mental illness is prevalent within the home. If there was intimate partner violence, if there was a family member that was incarcerated, or someone experienced divorce, is also in neglect, emotional and physical neglect. There is a way to evaluate individually someone's score using an ACE scoring tool. And what we now know about about the prevalence of adverse childhood experiences is they have lasting effects. So that's what I'd like to show you now, is what those lasting effects are. So 4 seems to be an important number for how many adverse childhood experiences someone experiences over before the age of 18. And so, as you can see here, an ACE score of greater than 4 or more is equal to, it increases your prevalence of certain medical conditions. So you're 240% more likely to develop hepatitis or a sexually transmitted infection, 390% more likely to have a COPD, 460% more likely to suffer from depression, and greater than 1,000% more likely to have attempted suicide. And so, and then what's amazing, and this is just so profound for me, because when I took this scale myself, my adverse childhood experience score was a 7. So an adverse childhood experience score of 6 or more shortened someone's lifespan by about 20 years versus age-controlled matches. So some really powerful information here that speaks to how the nervous system develops as we grow up, and then our ability to be resilient or cope and adapt later on in adulthood is often a function of what happens to us. And that's really the fundamental shift that we want to make within trauma-informed care practices, is thinking about what are these fundamental shifts in the way we care for people that will, that really allow us to shift our view from what's wrong with this person to what happened to the person.
Yeah, that's good.
And in clinical practice, this is already
no cars. This is pathetic.
In clinical practice, we're already experiencing people that are telling these deeply profound stories of traumatic experience.
This is really incredible.
And within the United States, anyway, our mental health systems are really struggling, and physical therapists are essentially becoming sort of the de facto mental health clinicians. So we are taking on the prevalence of these traumatic experiences. And as clinicians, we're listening to these things with an empathetic ear, and that does help us to build a connection and relationship. It does also expose us to the risk of secondary trauma or vicarious trauma. And so if you'll hold one moment, what I'd like to do is stop this slide presentation and pull up another one. So this is an example of what we'll be discussing in week 2 of the trauma-informed pain care course. These are the trauma-informed care guiding principles. And trauma-informed care comes from the Substance Abuse and Mental Health Administration, which is a function of the Health and Human Services within the United States government, that describes guiding principles of how to reduce the negative effects of trauma, both from the patient's perspective, but also from the clinician's perspective, and really acknowledges all of the components of experiences and the comprehensive view of experiences that people might have as they come into our healthcare system and environment. So within that, it considers the different types of traumatic experiences, which could include adverse childhood experiences. It could include natural disasters. It can include many different forms. And so we can come back at the end and address any questions as well about different types of trauma that people experience. And trauma-informed care guidelines have been developed really to provide the medical community with guidelines. And so that's what we will cover in week 2. So as we see here, there are 6 fundamental guiding principles for trauma-informed care. The first is creating an environment of safety. And we do this in a couple different ways. Both there's the physical space in which our patient moves into our clinic. There's also the personal space that we can create for our patients. And many of us already do these things routinely in clinical practice. Some of them are communication things that we're not necessarily intentional about, but we're doing. Things like motivational interviewing, where we ask questions, we give permission, we ask for permission when we give these questions. These things that really help the patient feel empowered. And anytime you enter into a relationship with someone else, especially whenever you are under threat, you feel the need to protect yourself. And creating an environment and a personal relationship built on safety is really helpful. It helps to lessen the power differential that is inevitable in anyone that's seeking help for something. And it begins to put that person at ease. And we'll talk about specific strategies to do that. Transparency and trustworthiness, the pathway to building relationships is always through transparent and accountable relationships. And we want to make sure that those processes are included within our care program. So if we have a clinic and we're a clinic owner, for example, we want to make sure we have policies and procedures and communication strategies that help to build transparency and trustworthiness. Also, peer support. This may be a new, well, it should be a new idea within the concept of physical therapy, especially if you're a physical therapist. But peer support is actually using someone's lived experience. And so if someone has had a lived experience of pain or trauma, then using that experience to build trusting relationships with those people that might not feel like they can build a trusting relationship with you. And so I'll give you an example of that. What that looks like from a clinical perspective is, and we all sort of do this inherently, and we just don't necessarily give it the right language. But so imagine we have three or four patients or clients in a clinic, and we are working with those patients and clients with their pain, regardless of the body part. But we know each individual person has a story. And so sometimes these stories are really powerful and they form a connection with other people. I can think back early into my clinical experience where I was in a total joint replacement center and watched how people would engage socially around around their shared struggle with pain within the confines of this hospital setting. And what seemed to be amazing to me was the social bonds that they created were actually forming this protection and encouraging each other through this process of recovery. And so what you're really talking about with peer support is using someone's lived experience to bolster their confidence in both the recovery process as well as the clinician. So we use this quite frequently at our facility. The second or the fourth is the collaboration and mutuality. And some of the guiding principles also within communication strategies like motivational interviewing are really helpful here to understand the power differential that exists when someone's under a level of threat, which is really what we're describing here in trauma and pain, is the sort of intersection of the threat appraisal. And so what we have to do is be very intentional about how we do things like our informed consent processes. So if we are really not being attentive to the nonverbal communication skills, nonverbals that our patients are providing us, then we're not paying attention to whether or not they feel if they have power to make a decision. This is also where it's helpful to provide people with choices. So we can give them choices so that they know, okay, I do have a choice in my care decisions. I always have a choice, because inherent in trauma is the fact that something else happened to you and we lose our sense of control. And so part of our restoration, part of our rehabilitation is to return control back to the individual so that they're moving in a direction of self-actualization. And so we'll talk about some of those things in the course as well. Empowerment, voice, and choice. Right now, if you think about the social issues that exist in our particular nation, I say our being the United States as a nation, there is certainly a movement toward increasing voice. And what we're really saying is people are tired of not being heard. They're tired of not being listened to, and they're tired of being told what to do consistently by our medical system. And they are seeking different ways to amplify and raise their voice. I pay attention to social media because I'm always interested to hear what people's perspectives on things. And when I'm listening to those things, I see a lot of people that have been traumatized by our medical system, and they no longer trust it. And the only way to regain that trust is allow people to have a voice without judgment of that voice. And so I think that's another thing that we'll discuss in this course as well. Also, another guiding principle is the recognition that cultural, historical, and gender issues play in the medical system, and how we can be much more intentional about how we address these issues within our clinical practices, and what that means for how we work through those issues in a relational context. Yesterday, I was a part of a leadership program here locally, and we took a look at the history of our city. And as we're looking through the history of the city over the last couple hundred years, people are constantly and continually bringing up traumatic experiences. And those are the things that were most memorable. The Mobile, Alabama was home to the last slave ship to leave Africa and arrive in the United States. And that had a profound impact in how our future as a city has moved forward. And so we have to be able to acknowledge those things within the clinical context, and how that level of trauma carries into the interpersonal space that we create with another human being, given our therapeutic context. So we'll describe ways that we can be more intentional about that as well. So that is trauma-informed care, and that is the trauma-informed guideline principles.
Just so those of you who know, the work that Jeremy does is really groundbreaking. There's not too many just professionals, really, no matter from any profession, whether it's mental health or physical medicine, doing this kind of work, which is why I wanted to share Jeremy and his work and his story with you. I think it's super powerful. There are some questions that came in that I want to just have Jeremy chime in on and kind of go through them. So Jeremy, I'm going to read these to you. They actually came in through the chat thread here, and then I received some emails early this week around this, topic and concept. So let's start with this one. I work primarily with athletes who are in good shape and healthy. How does a trauma-informed approach help if you're working with athletes, let's say in a college setting?
That's a great question. First, I was I was a college athlete. Played baseball in college, and before I moved into this trauma environment and chronic and persistent pain, I worked with I was assigned to a light infantry brigade combat team in the U.S. Army, and so I've worked with a lot of high level athletic folks. And I think the application of trauma-informed care within the athletic population is one, recognizing that that athletes have an identity, and within that identity often is their ability to be an athlete. So I remember thinking that I am a baseball player, and so I also went through some rehabilitation myself. And after going through that, or while I was going through that rehabilitation process, I remember feeling under threat, as if my identity was going to be taken away. And I was not I wasn't a good student. So I was banking on my ability to play baseball to really be, the way ahead for me and how I was going to survive and provide a living for myself. And so, one, there was a need for someone to identify that my identity was under threat, and to be able to create a safe environment that would allow me to communicate that, because the athletic environment is highly competitive. And I think that's one way in which that helps. The other part is, I think having the shared experiences from other athletes that have been through a rehabilitative process is the essence of peer support. So someone that's had a lived experience of recovery, matching that person up with another person that's had a lived experience, will bolster the athlete's confidence. And so we know a lot from the literature in things like ACL rehabilitation, for example. These psychosocial factors do play a pretty pivotal role in their ability to recover. So just leveraging, relationships to build a sense of social connectedness within the athletic population can be helpful. If, I think back to my military experience, and what they would do sometimes is pull someone out of the unit, and that isolated that individual, which generated feelings of hopelessness. So I think those are implications.
Excellent. Okay, we're going to go on to the next one here. And if you're obviously here with us live on the webinar, you can type into the Q&A section, and we'll go through those as well. So the next one is, how does trauma-informed care fit into a women's health PT practice where I may have to touch women in places where they were previously violated?
Oh man, yeah. So it's amazing to me the work that is required from a relational perspective to gain trust from someone to touch them in an area where they probably and potentially have been traumatized in the past. I think about, the women's health physical therapists that I know, the conversations that we've had, and how what we've talked about from a trauma perspective is the ability to identify trauma, and also work with that individual to help create this new story of resilience and their ability to overcome those things, while also being able to refer out to someone else for any of the behavioral aspects that they may need to deal with. And so I think those are a couple of things that I've talked with a lot of women's health physical therapists about is, do you have a strong relationship or consulting relationship with a behavioral health professional? And how do you communicate between those two for the best benefit of the patient so that that person feels safe, so that you're aware of anything that may be re-traumatizing the individual, and then also to be able to use the informed consent process as a way to build trust. So I think those are the applications that I've talked with some of my friends that are in women's health on this particular topic.
Okay, I always tell other professionals and people in our profession that some of the work that the women's health PTs have done in our profession and PT, I think is just so forward thinking, because they really were probably ahead of the curve on integrative care, biopsychosocial issues, and we're seeing that spill over. But I always try to give the women's health section, the respect they deserve for identifying things early. And kind of along the line is a question here in the chat thread: how does a therapist working with adults with chronic pain intervene when someone is carrying adverse traumatic experiences from their past?
Yeah, and I'm going to go back just for a moment, my last question. In 1 in 3 right now is the number for intimate partner violence in the United States. So 1 in 3 women have experienced some form of intimate partner violence in the United States. That's from work at the CDC. So think about the applications to women's health. I mean, it's unbelievable. And then this particular question about working with adults with chronic pain, how does it, well, first, I think it's a matter, from my perspective, my experiences, both personally and professionally, the value that the shift in perspective from what's wrong with you, in other words, let me go and evaluate someone from a deficit-based perspective. In other words, I'm going to go through and collect a whole huge list of all these things that are wrong with you or impairments, if we're using the ICF language. And then we're going to develop this plan of care to address these impairments. I think the fundamental shift that I've made in my personal clinical practice as a result of using the trauma-informed care guiding principles is that I want to recognize that your previous traumatic experiences may be influencing your ability to decrease the threat response and thereby decrease the amount and intensity that your pain, that you're experiencing. So that is a part of what we kind of know is pain neuroscience education. So we deliver this information about how the pain experience is, how, what the nervous system is doing. What I have found though is everybody's got this story, and everyone has this story, and they need to feel heard and they need to feel listened to. So if we're using the trauma-informed care perspective, what happened is what we really want to listen for. What did happen? So when we are hearing that, the essence of listening builds this therapeutic relationship to a greater degree than my previous experiences, where I was entering into this relationship looking at someone from a deficit-based approach. Now I look at someone from a strength-based approach, and I want to know, how did you manage to overcome the adversity that you had before? Like, what are the skills that you did learn before to overcome this adverse experiences, and how can we apply those today? So for me, if I look back at my own story, I know that, I was raising, essentially, by the time I was 9 years old, I was raising my brother and my half sister because my mom was incapable of doing that. Well, that's certainly been a strength for me, because I've been able to lead in many different ways that my peers were not able to. One, because I have empathy for suffering, and I can make a connection in a way that others can't. So I think that's how I've been able to bring in these principles into how I practice. Hopefully that answers that question.
There's a couple of questions here that are kind of the same theme, so I'm going to kind of summarize these all together in one question. So they revolve around a physical therapist either using psychologically informed care or treating trauma and knowing that currently trauma is looked upon as a mental health diagnosis, which
Mhm.
is a big topic for another time that we can all discuss, because some of the best research really shows that bottom up mechanisms, which is what we do as physical therapists often, are one of the most important parts of trauma care. And then there's some aspects of like mental health physical therapy. So just, knowing that within the last year, the APTA House of Delegates came out and said that it's within the PT scope of practice to screen for and intervene in behavioral and mental health problems. But just talking about, I really think kind of a lot of the work you're doing, Jeremy, is opening the world's eyes to the fact that PTs have a critical role in the mental well-being of patients.
Yeah. Yeah. And I think I feel strongly there's a need to integrate these sort of these constructs that we tend to isolate, and the medical system sort of forces us to do this. It forces us to divide our humanity into physical, emotional, spiritual, and so we try to treat people that way. We try to say, well, go to the physical therapist, and go to the behavioral therapist, and go to the clergy or the pastor person, or go to the primary care physician for your physical component. And we break these things up. And granted, each one of us have to have a scope of practice, right? Like we have a scope in which we can operate, yet all of these other functions seem to be influencing the individual that's right there in front of us. So how do we expand our ability to do that within the context of a relationship? And that's where I feel like we're not, a physical therapist can't own these things. We really like to claim ownership over areas of the body and the mind and the spirit, but we can't own them. We have to build working relationships and collaborations with other professionals for the sake and the good of the person that's sitting in front of us. And so we need to recognize both our professional scope of practice, but then our individual scope of practice, the things that we feel comfortable working with. So I would not feel comfortable working with someone that has a vestibular disorder, because I don't work real well with that. But I'm going to reach out to somebody and I'm going to ask them for help, because that's what the person in front of me needs. So those are the ways I think we need to be thinking as we relate to both the patient's needs and the system that we're working in. So there is this question that naturally arises where we ask ourselves, okay, like how far do we delve into the psychological aspects of care? And what I've come to learn and what I've come to experience as well is that we already do so many of these things. We already build relationships with people. We can just learn to optimize that. We already do things to bolster self-efficacy. We already do the things to make a person's pain experience feel smaller while their life feels bigger. And that's where we really need to expand as physical therapists, is understanding how we can help someone's life feel bigger so that their pain feels smaller. And I think that is where the opportunities lie, in terms of understanding that we are not this fragmented being. We are an integrated being of both mind, body, and soul and spirit. So I know that's not a direct answer in like, hey, we need to do this, but I do think it's one where we need to reconceptualize our idea about what physical therapists do and how they go about understanding the integrative nature of humanity.
Beautiful response. Lots of good feedback there, Jeremy, from people in the chat thread. They really like your response around the idea of seeing oneself, look, whether you're a PT or another healthcare professional, learning how to be an integrative professional, and then reaching outside your own scope if you need to, if you're outside your own scope, and then building relationships, but also realizing that right now we function in silos and we need to do less of that in our healthcare system here, especially in the US.
Yeah.
So here's one, a couple more here. Here's one which, when you're working with first responders, so police, firefighters, corrections officers, and there's a stigma with regard to seeking help, especially things that are involved in, the mental health arena. How do we approach that population and facilitate, their post-traumatic recovery?
Yeah, well, first, I'm thankful that you asked that question, because it means that you care, and that means a lot to me as a veteran, and someone who, has his own stigma about seeking help. And it recalls my own experience where I knew I was at a place where I was not where I wanted to be, not where I needed to be, and I was not healthy at all. And it took what it took for me, and I'm realizing it takes this for those folks that have been affiliated with the paramilitary cultures like police and law enforcement and fire and rescue, and also the military populations. It takes a trust broker, and that's what a peer support specialist is. It's something about this lived experience. Hey, I've been there. I know what that's like. I know you don't want to trust, in the U.S. military population, we used to call them, and I'm not saying this for everybody, but I will say that I used to think of psychologists as witch doctors, and that was a general culture of the military. So, and it also had implications for my career. So I couldn't necessarily reach out for help from my command and say, hey, I'm really struggling, because it would have implications for my performance in my career. So, what I've learned through that process, and now we do some consulting work with fire and rescue departments, is there's a culture that we need to recognize that has to shift, but it's hard to create a cultural shift. And it takes time, and it takes strong leadership. And so, that's a recognition we all need to have. The other part is creating spaces within those environments where people are willing to share their stories about recovery from mental health. Those are the stories that are going to influence the culture. Those are important. Those need to happen. That's why I'm so vocal about my own recovery experience, is because we need to be talking about this more. I think the other, thing that is really helpful, if you're seeing a lot of veterans, a lot of first responders, a lot of these kind of paramilitary culture types, then have you some connections with those folks that can come in and talk to these patients, right? And that you can kind of show them as models of what it's like to go through that process, what it's like to go through pain, what it's like, and then also leverage their strengths. And the strengths that are already inherent in the culture is bravery and courage and self-sacrificing, right? Some of those things can be detrimental, but if you view them from a strengths-based perspective, they can actually be extremely helpful. So talking out loud about your struggles, that's a vulnerability. But if you look at what vulnerability is, it's bravery and courage. And if you frame it in that way and say, hey, I know you're a courageous person. You know when something's scary, and you know that you can overcome it. So how do we use those same strengths in order to enter into this discussion about the trauma that you've experienced, and how do you show up in that every day? So I think just leveraging the inherent strengths of the culture in order to start to shift it is the way ahead for those paramilitary cultures. Hopefully that answered that question too.
Excellent. Okay, we're going to wrap up. We've gone through all the questions here. We thank everyone for staying on with us here and just negotiating some of those technical challenges with us. As I mentioned earlier, Jeremy's course does start today. It actually opens up tomorrow, Trauma-Informed Pain Care. It's about 5 weeks. There's 4 weeks worth of training with Jeremy. And then in the 5th week, there's a live mentoring and coaching call at the end of that. If you can't make the live session, that's fine. It'll be recorded and we'll share with you for later use. But the course is open. I believe I put the course link there in the chat thread, so you can click on it there, or you can go to the Integrative Pain Science Institute.com and just scroll over to courses, and Jeremy's course is at the top there, Trauma-Informed Pain Care. And we, of course, look forward to seeing you in that program. It's super important work. I mean, I think as you can all tell, this really hasn't been spread around the physical medicine world the way it should. Obviously, mental health professionals are more in tune to this, but we as PTs and other body-centric licensed health professionals, when you combine trauma-informed care with what you're currently doing, yes, it's a form of psychologically informed care, but more importantly, it's a way to help your patient move on to post-traumatic growth, which is what we're really looking for here. It's not just about resolving pain. It's not just about resolving trauma. It's about where's the growth that happens after that you've worked with the patient now. So how does their growth start to kind of seed and grow, basically? That's really where when I speak with Jeremy and I listen to the stories that he has about treating patients and where they were to where they are today, the post-traumatic growth is just, it's phenomenal. And it only happens if you can approach someone in a trauma-informed way. All of us care, we're all caring professionals, right? But trauma-informed pain care is a very specific way to communicate and to see your patient through a different lens. And that's really the beauty of it. So we hope you join us. Again, that you can go over to the Integrative Pain Science Institute.com and go over to the courses tab and scroll down to trauma-informed pain care. There will be a replay of this sent out within about 24 hours if you want to review anything. If you have any questions, you can reach out to us. Just I'll give you the email at the Institute. It's support@integrativepainscienceinstitute.com. That's support@integrativepainscienceinstitute.com. Again, I want to thank all of you for being here. I want to especially thank Jeremy for joining us on this Saturday afternoon, and we'll see you guys soon.
Thanks, everyone.